history taking, for that matter, we start with the basic demographic details, right? So in this demographic details, we take the basic information. So name of the baby, obviously the name will not be kept for the child, so we call it as baby of whatever the name of the mother is, followed by age. And one important thing in newborn history taking is always mention the age of the child in hours. Okay, always we mention the age of the child in hours up to initial 3 days of life. Okay, so since the problem that neonate gets in the initial 24 hours, in the next 48 hours and the 72 hours is different, it is better to mention it in hours rather than days. Okay, it will be more specific. So if we have a child or a newborn baby that is on second day, we, rather than presenting it as day 2 of life, we call it as either 36 hours of life or 40 hours of life or 42 hours of life. Okay, so that is a better way to present. Fine. So initial 3 days of life, we call it, we present it in terms of so and so hours of life. Okay, and we'll have to tell the sex of the child. Fine. And the race. Okay, because the different racial people might be subjected to certain diseases. Fine, they will be at a higher risk of certain diseases. That's why race might be important. Okay, next is the address, then date of birth of the child. And when we are examining, again, when we are examining, it is in the initial 3 days, better to call it in terms of hours of life. Fine. Who is the informant? Either the mother or the caretaker, like someone might, grandmother might be there, or the father might be there, and the socioeconomic status of the parents. Fine. So this is the basic demographic details. After demographic details, we'll come to the chief complaints. Usually the case which will be given to you guys is either a normal newborn or a newborn with neonatal jaundice or a low birth weight newborn, correct? So what do we tell? If it's a normal newborn, we can tell it as routine postnatal care. If it's yellowish jaundice, you can call it to be yellowish discoloration. If it is low birth weight, you can either tell if like baby is here for weight gain, or it is a low birth weight baby, or if any issues the child baby has presented with, you can tell that as well. So issues can be anything. It can be a low birth weight baby, which is there for weight gain, or it has been admitted to NICU because of like baby not being having cried at birth, so it is having birth asphyxia, now shifted to postnatal ward. Okay, for step down care. Or it can be like neonatal conversion, so abnormal movements can be the history, or it can be baby having any features of like early onset sepsis or late onset sepsis. So baby might present with lethargy, not feeding well. Okay, so anything can be the issues. Fine. So but usually what will be given is either a routine new or normal newborn. Okay, so routine postnatal care which will be kept for you guys, or yellowish discoloration, that is neonatal jaundice, or a low birth weight baby. Fine. Next what you will take. This will be a slight, from here onwards there will be a slight deviation from our routine history taking as compared to other cases, correct? So next we'll start with maternal history. Fine. Now why is maternal history important? To see whether there are any high risk characteristics that is present in the mother. So we'll have to give extra attention to mother, and if any of these high risk characters will cause any disturbance to the baby's growth, or will cause any issues to the baby. Fine. So that is why the maternal history becomes important to us, correct? So in maternal history, we'll see the first thing is the age of the mother. Now, how is age of the mother important? Either if the mother is less than 16 years, or if mother is more than 30 years, we call them to be high risk pregnancy, correct? So either less than 60 years or 30 years, child can be low birth weight, or it can be born early, so preterm child can occur, or there is higher risk of stillbirth, correct? So all these things are associated with this high risk pregnancy. So age of the mother becomes important. And they can ask you who is an elderly primi gravida. It is called elderly primi gravida if the mother's age is more than 30 years with first pregnancy. Okay, so elderly primi gravida, in your viva you might be asked what is the definition. It is more than 30 years. Why is it important? Again, as told, there can be increased risk of abortion, increased risk of preeclampsia in the mother. If there is preeclampsia in the mother, then there can be the uteroplacental insufficiency will be there. So the blood flow to the baby might not take place. That will lead to baby being born IUG, or intrauterine growth restriction might be there. So we will have low birth weight babies, correct? Then if there are higher chances of preterm labor. So if there is preterm labor, again, there can be low birth weight babies, and the many risks associated with, or the disease nature associated with preterm labor, correct? Next, IUGR, as already mentioned, and there is higher risk of congenital malformation with increasing age. Fine. Next, we will see the consanguinity. Okay, whether the baby is born to non-consanguineously married couple or consanguineously married couple. Here, the most common question that will be asked is what is first degree, what is second degree, and what is third degree relative. Fine. First degree is when they share 50% of the genes. Okay, so this will happen when they're either parents, children, or siblings. Fine. Next is second degree consanguinity. Second degree consanguinity is when they share 25% of the genes. This will be either uncle or nephew, okay, or aunt or niece. So they will be the second degree relation. Fine. Third degree will be, they'll be sharing 12.5%. Okay, they will be usually the first degree cousins. First degree cousins will be third degree. Fine. So this we all know, just to revise. Okay, first degree, second degree, and third degree. So this is basic details, and like most of you, as soon as you utter the word consanguinity, will be asked in Viva as to what is first, second, and third degree. Next important thing is obstetric score. You'll ask in the mother. So gravida, para, living, and abortion. Okay, gravida, which will include the present and the past pregnancy. Okay, gravida will include present and past pregnancy. Okay, next is para. Para will be past pregnancy, which will not include present one. So past and viable pregnancy. Okay, past and viable pregnancy it will include. So gravida is past and present, para is past and viable pregnancy, next is living, okay, and next is abortion. Fine. Details of the abortions, we will have to mention it, which we will see later. Fine. Next, we'll ask about spacing. If it is multiparous women, we'll ask about spacing. Minimum spacing should be between 2 to 3 years. Okay. Next, we'll have to know about mother's blood group. Okay. How is it important? It can be because we'll have to look for, if the child presents with jaundice, then we'll have to look for neonatal jaundice and neonatal jaundice, RH incompatibility or ABO incompatibility. Fine. So mother's blood group is important. Next is pre-pregnancy weight. This as well is very, very important. Usually we tend to miss this information, but pre-pregnancy weight has to be mentioned. How is it important? We'll see later. We'll very soon see it. Okay. Next, height of the mother should be measured. This also is very important because mother can be short primary. When do we call her short primary? Less than 150 centimeter. Again, she becomes high risk pregnancy because she can have CPD. So that will lead to child not being prolonged labor, or she might not be able to deliver the child. So we'll have to take her up for cesarean section. Okay. So height of the mother is important, and height is also important to calculate BMI and to know the nutritional status of the mother, because the nutritional status of the mother as well will have an impact on baby and its birth weight. Okay, so that is why it is important. As already mentioned, it is BMI. BMI, we'll get to know the nutritional status. Okay, and if obese, okay, if one is malnutrition can be present. Okay, malnutrition, undernutrition can be present. Both obesity and undernutrition can be present. If there is obesity, mother can be predisposed to hypertensive disease of pregnancy, gestational diabetes mellitus, and both of this can have a bearing on the newborn child. Okay, mother might have miscarriages, and this GDM itself can cause fetal malformation. Correct. Macrosomia can be there, and while delivering the child, shoulder dystocia can be there. That can lead to clavicle fracture. Correct. Or undernutrition can lead to low birth weight and IUGR babies. Okay. Next is, what is the weight gain? This is again another important Viva question, whether it is adequate or not. Adequate weight gain is somewhere between 11.5 to 16 kgs based on the BMI. Okay, if there is normal BMI, then it is usually between 11 to 13 kgs. If mother is having undernutrition, then we expect slightly higher weight gain up to 16 kgs. Okay, and occupation of mother is important, because if she is doing any strenuous, stressful or which is physically demanding, then we'll have to advise a good amount of rest, correct? So occupation is important. And if there is any other significant past history or any other systemic illness that mother is suffering from, and fine. Next, coming to the same, like maternal history, we'll have to take paternal history as well. Now, again, paternal increasing age, the increasing age of the father is associated with certain syndromes like Eppert syndrome, Crouzon syndrome, Noonan syndrome, okay, multiple endocrine neoplasia and achondroplasia, right? So these are few syndromes that is associated with increasing age of the father, fine. Next, again, blood group is important. Okay, we've already seen why is it important and why is it important. Occupation of the father is important, and any history of paternal illness. Okay, so this is the paternal history. Demographic details we have to see. Then the chief complaints. Then we start with maternal history. Then we go to the paternal history. Fine. Next is the past obstetric history. So we have already seen the obstetric score. Now we'll have to go back and explain why. Because whether the baby is at any risk depending on the past pregnancy. So what are the details we are expected to ask if the mother is having any significant illness, okay, during the pregnancy, if mother has had any significant illness in the past, because mother might have had one of the tortuous infection in the past and she might not have been treated, then this baby might as well be at higher risk, correct? So our mother might have had preeclampsia, now she is again at risk of that. Mother might have had GDM, now my mother might be again at risk, okay? So significant maternal illness during the pregnancy should be asked for. And what are the delivery details, whether baby cried immediately or not, if there is any, if baby did not cry, if the child had birth asphyxia, then what might have been the cause? The mother might have had CPD, gone into prolonged labor, or might have gone into transverse arrest. So all these things, deep transverse arrest might have taken place. So delivery details is important, and birth weight is important. Why? If mother has had low birth weight previously, then even this baby is at risk for low birth weight baby, okay? And any other problems and factor during delivery, okay? Any significant neonatal history. Again, this is also important because if the baby has had neonatal jaundice, this baby is again at risk. If baby has had any neonatal convulsions or any inborn error of metabolism which has presented early in life, this baby as well might be at risk, okay? So if the baby has encountered any other significant neonatal history, and presently whether the child is active and healthy, fine. So these are the details. And if any abortion has taken place, whether it was first trimester or second trimester abortion, and if mother knows any details regarding that, we'll have to take details regarding the abortions and stillbirths as well. Why we do all these things, as told earlier, to see whether the baby that is being delivered now is at risk or not. Okay. Now next is the antenatal history. Now coming to the antenatal history, we start with whether the baby has had spontaneous conception or assisted. Okay, if they have tried assisted delivery, if any in vitro fertilization has been tried, again, there is increased risk of twin delivery, there is increased risk of preterm child, there is increased risk of IUGR, okay, there is increased risk of chromosomal anomalies. Okay, that is why whether it is spontaneously conceived and it automatically becomes a high-risk pregnancy. Okay, assisted delivery, assisted conception is important. Okay, next is the birth order. We've already mentioned. Okay, next whether the child is, whether the mother is registered or not. Presently, we usually don't use the term booked case. Okay, we use it. The terminology has changed, whether it is registered or not. Okay, and next is the antenatal visits, and minimum number of visits that is recommended is 4. Correct? 1 in first trimester, 1 in second trimester, and 2 in the third trimester. One is between 32 weeks, and other one is after 36 to 37 weeks. Okay, so minimum 4 visits is necessary. Next is LMP and EDD. Okay, LMP and EDD we calculate. Okay, and if there is any history of alcohol, tobacco, or any other illicit drug abuse, this can again have effect on the child. Alcohol, baby might have fetal alcohol syndrome. Correct? So if there is any other illicit drug abuse, fine. Coming to the first trimester history. Coming to the First trimester history. Initially, we ask for dating scan and how EDD was conveyed. EDD will ask for dating scan. We'll look for the expected date of delivery. We'll look for the crown rump length. Then we look for whether we'll then what the number of babies that is present, and we will confirm the delivery. Okay, so all these things can be known by doing the dating scan between. This is usually done between 9 to 11 weeks. Okay, and following dating scan, even NT scan is done. Correct, NT scan is done, and okay, this is done between 11 to 13 weeks. 11 to 13 plus 6. Okay, so 11 to 14 weeks. Okay, and by this, what we'll get to know, we'll see the nuchal translucency if it is less than 3 mm or more than 3. Okay, if it is less than 3, then we'll see there is no risk, and if it is more than 3, then the baby is at risk of trisomy. Correct, trisomy 21 can be there, at risk of trisomies. So NT scan becomes important. The NT scan is done between 11 to 14 weeks, and dating scan is done between 9 to 11 weeks. Next, we'll ask whether folic acid is taken or not. This is again a very important history, and many Viva questions will be asked on folic acid. Okay, ideally it has to be started 3 months preconceptionally. Okay, ideally 3 months, at least 1 month preconception, we'll have to start the mother on folic acid. And how much to give? If it is a preventive dose, it is 400 micrograms. And if there is any previous history of neural tube defects, then we either give 4 mg or 5 mg. Different textbooks mention either 4 mg or 5 mg. Okay, routinely 4 mg is followed. Fine. This is very important. Folic acid. So started 3 months prior. Okay, given in the first trimester and continued in the second and third trimester as well. Okay. Next is history of any infections. Infection. How we'll ask the mother if there is any fever, if there is any rash, and if there is any lymph node swelling, to rule out torch infection, intrauterine infection. Okay. Next is drug history. Okay, and it is always better to remember 4 to 5 drugs and what are the teratogenic effects caused by these drugs. So always remember few drugs like methotrexate, which can cause CNS and limb malformation. Lithium can cause Epstein's anomaly. Correct. Warfarin can cause Contradi syndrome. Valproic acid can cause neural tube defects. So you can go through this table and remember minimum 3 to 4 drugs that will be asked in your Viva. So just go through this list and try to remember as many as possible, but at least 3 to 4 drugs have to be remembered. Next is the radiation, exposure to radiation. Now again, coming to exposure to radiation, this is the Viva question that will be asked for you guys. So it should be less than 50. Okay, radiation exposure should be less than 50. Now next is the first trimester history. So we have taken. Next, let's go to the second trimester. Okay, second trimester, we'll see ask for anomaly scan, which is done between 18 to 20 weeks. Anomaly scan is done. We'll ask whether what had happened or whether any defects were present. Okay, next 2 doses of TD, whether it is taken or not. Okay, and then in second trimester, we also start with iron and calcium supplements, which is not given because of hyperemesis that is present in the first trimester. We start this in the second trimester. Dosage is again important. Okay, 100 mg of elemental iron is given or 500 mg of calcium is given. So either 100 mg of elemental iron or 500 mg of calcium. So iron, calcium, and folic supplements is given 100 mg before and 100 days before delivery and 100 days after delivery. Okay, so iron, calcium, and folic acid supplements to be given. Next, we'll ask when was the quickening felt? When was the quickening felt? This is between 16th to 18th week of pregnancy. Okay, so if there are decreased fetal movements present, then we'll suspect congenital myopathy or spinal muscular atrophy. If there is increased perception of movements, then we'll be suspecting neonatal or fetals having seizures. Okay, so this is about quickening. Next, we'll ask any history suggestive of the maternal illness that can be present. So what are the maternal illness that occurs usually during the second trimester? One is pregnancy-induced hypertension. This can include headache, blurring of vision, giddiness, swelling of lower limbs. So these are the symptoms which you will ask for. Next is the GDM. This can be polyuria, polydipsia, polyphagia, and OGTT test, that is oral glucose tolerance test, that is done at 22 to 24 weeks. What is the result of that? Okay, so this and any other chronic maternal illness that mother is having, like mother might be suffering from seizures, she'll be taking one of the anti-epileptic drug like valproate, and this valproate can cause teratogenic effect. Correct? So we'll ask regarding any particular chronic maternal illness that mother is suffering from. And again, fever with rash if mother has had any burning maturation, that is UTI, again the baby born will be at high risk of sepsis. Okay, any bleeding PV or any other white discharge per vagina or pain abdomen. So these are the histories that you'll ask in the second trimester. Fine. Next is the third trimester. Third trimester, whether the mother continue to feel perception of fetal movements. Okay, any other risk factors for sepsis or any other risk factors that is present for asphyxia in the newborn baby. Okay, so we'll ask for leaking or bleeding PV, or PROM. We'll ask for PROM is premature or pre-labor rupture of membranes. This is used for children more than 37 weeks, and PPROM is preterm pre-labor rupture of membranes. Okay, so this is for less than 37 weeks. This is for more than 37 weeks. Fine. That is asked any foul smelling vaginal discharge that was present, or pain abdomen that was present. So all these things might tell that there is high risk of chorioamnionitis in the mother, and if that is present, the baby is at risk of sepsis. Fine. Next is whether the supplements that was prescribed has been continued by the mother or not, and ask about the growth scan, which is done at 28 to 30 weeks, and amniotic fluid. We ask for whether there was any meconium staining. Fine. If there is meconium staining is present, that means fetal distress has taken place. Okay, so if fetal distress is there, then either meconium aspiration syndrome can take place, or meconium has been passed, fetal distress is present, so baby is at risk of birth asphyxia. Fine. And hemoglobin status before the delivery, that will reflect the HB status of the baby as well. Fine. So this was the antenatal history which we spoke about, first trimester, second trimester, and third trimester, and focused points which we'll have to ask for. Next is the natal history. Correct. So in natal history, what we'll ask, what was the presentation, whether it was vertex or breech. If baby is born breech, baby is at risk of dislocation of hips can be present. If there was shoulder, then baby is at risk of clavicle fracture. So all these things can be present. So presentation becomes important. And on the partogram, if there is any history of fetal distress that is present. Okay. Next is the mode of delivery. Fine. If it is vaginal delivery, and if vaginal delivery, if whether any assistance was needed, like whether any instrument was put or any vacuum was put, again this will indicate that the delivery was difficult, it has taken longer time, so again the baby might be at risk of birth asphyxia. Correct. Next, if C-section was done, cesarean section was done, what was the indication for the same? Fine. Next, they might ask you, what is a normal vaginal delivery? Okay, definition of normal vaginal delivery. So listen properly. It is expulsion of the products of conception, after 37 weeks. So it should be a term baby. Okay, so after 37 completed weeks of pregnancy with vertex presentation, via the naturalis. So it has to be a vaginal delivery with or without episiotomy, which after birth shows signs or evidence of life. So this is when we term it as normal vaginal delivery. So to term it as normal vaginal delivery, I'll repeat the definition once again. Expulsion of products of conception after completing 37 weeks of pregnancy with vertex presentation being present, with via the naturalis, with or without the episiotomy, which after birth shows signs or evidence of life. This is what we call it as normal vaginal delivery. Fine. Then onset of delivery, whether it was spontaneous or assisted, okay, or induced delivery. Fine. Next, amniotic fluid. Again, if it was clear, or meconium stain, and the importance we have already spoken about. Duration of labor, because if there's again prolonged labor, it can cause, there is risk of birth asphyxia, there is risk of the membranes being ruptured, again ascending infection can take place. So early onset sepsis can be there, correct? So duration of labor is important, and any other significant events that causes the baby to be at risk for birth asphyxia and early onset sepsis. This is the natal history which we'll have to take. Next comes the postnatal history, once the baby is born. Okay, so what we'll ask the mother, whether baby cried immediately after birth or not. If not, if mother is aware of what is the resuscitation details, correct? We'll, since it is in terms of mother's own word, mother might tell that baby, a tube was put into the baby's mother, or baby did not cry, they wiped the baby, then the baby started crying, correct? So in mother's own terms, if mother knows the resuscitation details, you can go ahead and ask. Fine. Next is the Apgar score. So again, this is a very important Viva question. What is Apgar score? So this is the most practical method of systematically you will evaluating the baby after the birth. Okay, so it is done at 1 minute, 5 minutes, and if the score is less than 7, we go ahead and do it 10, 15, and 20 until the baby reaches an Apgar score of 7. Fine. So Apgar score, it was given by Virginia Apgar, and it stands for A for appearance, P for pulse, okay, G for grimace, A for activity, and R for respiratory efforts. And based on this, a score of 0, 1, and 2 is given. So you need to know the components of Apgar. I'll repeat once again. A for appearance, P for pulse, G for grimace, A for activity, and R for respiratory efforts. And a score of 0, 1, and 2 is given. And we do it at 1 minute, 5 minutes, and if the score is less than 7, we again go ahead and do it at 10, 15, and 20 minutes as well. So it rapidly assesses the cardiopulmonary status of the child. And if there is low Apgar score, the changes in Apgar score with sequential time, that is at 5, 10, 15, and 20, it shows that how well the baby has responded to the resuscitation efforts that the neonatologist or the doctor has put in, correct? And it should be used as a guide to start resuscitation. Fine. And it is a poor predictor of long-term neurodevelopmental outcome. Okay, it is a poor predictor of long-term neurodevelopmental outcome. When to measure, as already told, 1 minute and 5 minutes. Okay, if score is less than 7 at 5 minutes, then we go ahead and do it every 5 minutes for up to 20 minutes. Fine. Next, we'll ask the birth weight of the child, and how we'll see down the lane as to how do we classify the newborn based on the birth weight. Okay, so what is the birth weight? Definition is first best recorded birth weight anytime before 24 hours. Okay, why before 24 hours? There might be less staff available, the mother has delivered the baby, so most of the staff will go concentrate on the mother, correct? So it might take another half an hour or 1 hour to weigh the baby. So within 24 hours, anytime within 24 hours. Okay. Next is the gestational age, whether the baby born is preterm, term, or post-term. And next we'll ask about the details of breastfeeding. So when to start breastfeeding? As early as possible. Okay. Ideally as early as possible, but within 30 minutes of normal vaginal delivery and within 1 hour of cesarean section, breastfeeding has to be started. Next, we'll ask about the adequacy of breastfeeding. Okay, so it can either be subjective as noticed by the mother, or we look into it, that is objective. So subjective, it is 4 points. Okay, 4 points. It sleeps 1 to 2 hours post feeds, urine output 6 to 8 times per day, dribbling of milk on the opposite breast while feeding. So these are the 3 points. Baby sleeps adequately 1 to 2 hours post feeds, urine output is good, that is 6 to 8 times per day, and dribbling of milk on the opposite breast while feeding. Next, what is the objective score? Objective score, we weigh the baby and see, and we look whether any weight gain is present, and if weight loss is present initially for 1 week to 10 days, there is weight loss that is present, that we all know. But if it exceeds the recommended weight was cut off, then we can say that the breastfeeding is not adequate, correct? So initial 10 days, up to 10% in term is accepted, and up to 10 to 15% in preterm is accepted. Beyond this, we'll have to think that baby is going into dehydration, secondly to inadequate breastfeeding. Fine. Next is passage of urine and stools. And next important, this is also a very important Viva question. For urine, we can wait up to 48 hours, and for stools, we can wait up to 24 hours. Fine. Next, any other clinical problems that is present: respiratory distress, yellowish discoloration, lethargy, refusal to feed, and you go on explaining. Fine. Next is the immunization history, whether BCG was given, hepatitis B was given, OPO was given, and vitamin K, though not part of immunization, you can ask vitamin K. Okay, what is the dosage they'll ask? 1 mg for more than 1 gram, more than 1 kg baby, and 0.5 mg for less than 1000 grams. Okay, less than 1000 grams. Next is the family history, whether there was any history of early infant death or early neonatal death. Okay, the baby might have had inborn error of metabolism presented on day 3 of life, not noticed. The baby might have passed away, or the baby might have had congenital adrenal hyperplasia, which also present during day 3 to day 4 of life because of electrolyte imbalance. Okay, the baby might have passed away. So that is important, whether there is any history of early neonatal death. Okay, whether there is history of recurrent abortions, and previous siblings, if there was any anomalies present, and whether any chronic illness was present. That will become history. That will become important. So finally, you summarize it. How do we summarize it? So if less than 3 days, we call it in hours. If more than 3 days, these many days old baby, which is boy or girl, born to first degree, second degree, or third degree consanguineous married couple or non-consanguineously married couple with obstetric score of G3, P2, L1, so whatever it is. Okay, delivered by, whether it was normal vaginal delivery, or whether it was assisted, or whether it was a cesarean section. And if cesarean section, what was the indication? With birth weight of so and so, baby having cried immediately after birth, with significant postnatal history of whatever the presenting complaint is. Okay, and then whether exclusively breastfed or not. And we'll also have to ask in the breastfeeding details whether any top feed was given. Like there is a tendency to give honey, correct? There is a tendency to give as per the traditional requirements, whatever they've given. So it is also important to ask regarding that and counsel the parents and attenders as to not to do that, and like motivate them to give exclusive breastfeeding. Okay, and whether the breastfeed given was adequate or not, present weight of the child, immunization status, and the presenting complaints. So that is how we summarize. So until now, what we saw was for a normal newborn. Okay, now the other 2 cases that can be given is neonatal jaundice and a low birth weight baby. Correct. So we'll see now for neonatal jaundice and low birth weight baby, what are the specific questions we need to ask. The history taking pattern remains the same, but here and there, whatever the extra questions which we need to ask, or which we need to ask to the parents in a history taking is added over here, or the questions that you guys will be asked in the Viva, that is being added over here. Okay, so neonatal jaundice, when it comes to, so in demographic details, age and race might become important. Age, why the presenting complaint, like it becomes pathological jaundice if jaundice was within the first 24 hours of life, or it becomes prolonged jaundice if jaundice is persisting beyond 2 weeks in term babies and beyond 3 weeks in preterm babies. Correct. And if it is breastfeeding jaundice, they usually present within first week of life. If it is breast milk jaundice, they present at 3rd or 4th week of life. And prolonged jaundice, as already taught, it is more than 2 weeks in terms and more than 3 weeks in preterms. So if at all they ask what are the causes of prolonged jaundice, common causes will be inadequacy of breastfeeding, or there can be breast milk jaundice, or neonatal cholestasis syndrome can be there, or conjugated the hemolysis, whichever was present, it is still being continued. Or rare causes can be like cephalomatoma, which is extravasated blood that is resolving and jaundice is still persisting, or baby might have had hypothyroidism, for which we'll have to make the baby undergo the newborn screening, or Crigler-Najjar syndrome can be there. So these are all rarer causes. Okay, so these are the causes for prolonged jaundice. Next, if at all we know you have a transcutaneous bilirubinometer, or the parents have come with the report, with the total bilirubin reports, like the STB values might be 16, STB values might be 18 at day 3 of life, then we'll have to go plot it on the normograms. This I've already explained in the neonatology class, so you can go back and see those charts which are given by NICE guidelines. We go plot it over there and see whether the baby needs phototherapy or not. Okay, and then sex of the baby is important, because male child more prone for G6PD, correct? G6PD deficiency, if they have, they can present with neonatal jaundice. Fine. And race, as already mentioned, if East Asians, Greek and American Indians are more prone for neonatal jaundice, more prone to develop neonatal jaundice. Chief complaints, again, yellowish discoloration noted on which day of life will be the chief complaint. Now coming to history, onset, day of life, we already know the importance. Just now in demographic details we went through how it progressed. Initially cephalocaudal progression, so mother will explain it as initially seen in the eyes, then progressed to involve presently palms and soles. Okay, so how it progressed is important. And duration, how long the baby was put under phototherapy, and we'll ask for the history of etiology as to what has caused this neonatal jaundice. For this we have a mnemonic, that is jaundice itself. So jaundice within 24 hours of life, we call it as pathological jaundice. Asian race, they are more prone for neonatal jaundice. Under 37 weeks, usually preterm newborns, since preterm newborns, the enterohepatic circulation and gut is not fully developed, they are more prone for neonatal jaundice again. Okay, N is nursing. Nursing is nothing but the feeding history. Again, breastfeeding jaundice can occur if the baby born is not breastfed properly. So the history of breastfeeding becomes important. Okay, D is for deficiency. So deficiency is nothing but any enzyme deficiencies that are present, like G6PD, family history of G6PD. So, or history of significant jaundice present in the previous sibling. Okay, so D is for deficiency. I is for incompatibility. Here you will ask for mother's blood group and baby's blood group. So if there is RH incompatibility, or to see whether there is ABO incompatibility, we go ahead and ask for the blood group of both the mother, father and the baby. Okay, C for cephalomatoma, if it is present, then it will again might take few weeks for it to drain, so 3 to 4 weeks the jaundice might be present. Okay, E is for elder sibling, whether the previous sibling also had neonatal jaundice. If so, the present baby is at a higher risk. So these are the, in your HOPI, this is the etiological history you'll ask for. So in a HOPI, you'll initially describe the onset, then progression, then duration, and then you look for any etiological clues for the jaundice that is present, and any other significant history like IDM mother, again infant of diabetic mother, the baby is more prone for jaundice, or any maternal drugs like oxytocin can cause, or mother if she's taking any benzodiazepines, that can cause increased risk of neonatal jaundice. Delayed cord clamping is associated with increased risk of jaundice, and infants with birth asphyxia, they are also more prone for neonatal jaundice. Okay, so these are the etiological clues you'll ask for. After etiological issue, you'll ask for complication. So what is the complication that we are expected to have? That is bilirubin induced neurological damage or acute bilirubin encephalopathy, correct? In detail regarding acute bilirubin encephalopathy, we have already discussed in the neonatal jaundice lecture, so you can always go back and see. You'll ask for high pitched cry, lethargy, convulsions, poor feeding, if at all any of these symptoms are present in the baby or not. Fine. Next is these were the questions pertaining to neonatal jaundice. Fine. Now we look into low birth weight. Okay, so this will be our last topic, that is low birth weight. So initially we saw how to take history in newborn, normal newborn. We went through the full proforma. Next, we came and saw neonatal jaundice. Over here, we saw, along with the routine proforma, what are the extra questions that need to be asked and what probable viva questions you will be asked for. And next is the low birth weight. babies. So in the neonatal jaundice, you guys need to be thorough about the theory part of neonatal jaundice as well. And this, as I've already told, has already been covered under the neonatology lectures, which is there already in the YouTube. You can always go back and see the lecture. Fine. Next is the low birth weight baby. Okay, now coming to low birth weight baby, over here you might have the examiners in normal newborns, or over here you might be asked about certain definitions or terminology. Okay, so what is neonate? 0 to 28 days of life. Early and late, it can be classified into early is the initial 7 days of life, and late is from day 8 to day 28. Fine. Next is the maturity. Based on maturity, how do we classify the newborn? Preterm, term, and postterm. So preterm, again, how do we classify? Extreme preterm, less than 28 weeks. Very preterm, 28 to 32 weeks. That is 28 to 31 plus 6 weeks. Okay. Moderate is from 32 to 34 weeks, and late is 34 to 36 weeks. This is how we classify preterm. Next is term baby. Term is again classified into early term, 37 to 39 weeks, 38 plus 6, 38 weeks plus 6 days, or 39 weeks. Fine. And late. So over here there is a slight change. The present 2022 update says that the present 2022 update says that after early term we divide the term babies into full term or late term. Fine. So what is a full term baby? Full term baby is from 39 completed weeks to 40 weeks plus 6 days. Okay. So in between 39 completed weeks to 40 weeks, 6 days is full term. And what is late term? Late term is between 41 completed weeks to 41 plus 6 weeks. Okay, 41 plus 6 weeks. So this is the recent update. So we divide term babies into early term, full term, and late term. Fine. Next is the post-term babies. Post-term babies are more than 42 weeks. Fine. So this is how do we classify neonate? One is based on the maturity. We have seen preterm, term, and post-term. Second is based on the birth weight. So low birth weight baby is any low birth weight baby is between 2.5 kg. Okay. Among low birth weight babies, we can again divide them into 1.5 to 2.5 kg, which are low birth weight, 1 to 1.5 kg, which are very low birth weight, and less than 1 kg, which are extremely low birth weight. So extreme, very, and low birth weight. Fine. Macrosomia is anything more than 4 kg. So now we have divided the newborns as per maturity. Second, we divided newborns based on the birth weight. And third, we'll divide the newborns as per the gestational age and weight. Okay. So for this is based on the intrauterine growth charts. Again, the picture of this intrauterine growth charts, like Fenton's chart, and how do we plot is already described in the newborn sessions that has been taken previously. Okay. So based on the gestational age and weight of the child, for that particular gestational age, like if we have a 34-week baby, for the 34 weeks, whether the baby is having adequate weight or not, adequate birth weight or not. So for that particular corresponding gestational age, whether the baby is having adequate or appropriate birth weight or not. So based on this, we classify babies into small for gestational age, that is less than 10th percentile, appropriate for gestational age between 10th to 90th percentile, and LGA babies, large for gestational age, that is more than 90th percentile. One of the doubts was to repeat maturity part one more time. I'll do this in the end. Okay, I'll do this in the end. Next is the low birth weight babies. Okay, now the low birth weight babies, how do we classify? We already saw one is preterm birth. Okay, so they are less than 37 weeks and born low birth weight, so less than 2.5 kg there, or they can be either belong to this category. Okay, they are small for gestational age, and these SGA babies are, like, we'll see the difference between SGA and IUGR, but they're usually used synonymously. Okay, either SGA babies or IUGR babies, or they can be a preterm baby, which is IUGR. So both they can be. So low birth weight babies can be either preterm birth babies or an SGA IUGR baby, or a preterm baby that is IUGR. Okay, fine. Now, what is the difference between SGA and IUGR? Okay, this again you might be asked if you are doing very well in your Viva exams. Then next tendency is to ask difficult questions, correct? So even if you do well in this as well, you'll get really good marks. Fine. So what is the difference between SGA and IUGR? SGA babies, the definition we already saw, that is birth weight less than 10th percentile. It means that for that corresponding gestational age, birth weight of the baby is less than 10th percentile. Okay, so this is SGA babies. What is IUGR babies? IUGR babies are the ones that are determined by the scans which are done in the 3rd trimester, correct? We do something called as growth scan, correct? Over there, on doing that, if we get to know that there is diminished growth velocity in the fetus, and how is it documented? As documented by at least 2 intrauterine growth assessments. So when we do growth scan, if we see that the growth velocity of the baby fetus is lesser as compared to those at that particular gestational age, normal babies at that particular age, and this is seen in 2 consecutive growth assessments, then we tell it as IUGR. So IUGR is a terminology used for the fetus. SGA is the one which is used for newborn baby. So it is a very subtle difference, but usually it is used synonymously, SGA and IUGR babies. Fine. Now, once we get to know the baby's SGA or IUGR, then we go ahead and calculate ponderal index. Why do we do this? We do this to see whether the SGA babies, the insult that has occurred is in the 1st trimester when the organogenesis is taking place, or later on in the 2nd and 3rd trimester. Fine. So we divide them into asymmetric IUGR or symmetric IUGR by this formula. Fine. Asymmetric IUGR when ponderal index is less than 2, and symmetric IUGR is when ponderal index is more than 2. Fine. So asymmetric IUGR babies in the 2nd and 3rd trimester, symmetric is early in the pregnancy. So symmetric IUGR babies, the head and body will be proportionately smaller, whereas in asymmetric IUGR, head would have grown well in the 1st trimester itself. So head will be larger as compared to the rest of the body. Fine. That is why asymmetric IUGR is called as head sparing IUGR, and symmetric IUGR is proportionately small. Fine. Then how do we differentiate it? Asymmetric IUGR babies, they have little subcutaneous tissue, they'll have peeling or loose skin folds, they will be present, they look wasted, that is groin skin can be present, or axillary skin folds can be present, and meconium staining can be present. Fine. Whereas symmetric IUGR babies, they can have significant intrinsic fetal problems. Okay, fine. So this is how we differentiate asymmetric IUGR from symmetric IUGR. And if you get a low birth weight baby for your exam, definitely we will be questioned regarding all these things. So this is low birth weight baby. Till now, whatever I've discussed might not be part of your history, but these are very, very important Viva questions pertaining to low birth weight babies. So these basic questions you guys will be invariably asked in your Viva exams. Fine. Next is coming to the history. Okay. So what are the chief complaints? Chief complaints can be the child is either there for weight gain or for preterm care, or the baby has had any complications like RDS can be there, hypoglycemia can be there, the baby might not be able to feed, correct, early onset sepsis can be there, or and presently it is in the shutdown or correct. So this can be the chief complaints. Next is maternal history. In this modality, less than 60 years and more than 30 years, there is increased risk of births. And consanguinity, if the consanguinity present, abnormalities of can be there. This can lead to symmetric IUGR. This also lead to preterm baby. Correct. Obstetric score. There will be you are in the obstetric score. Correct. So multiparous women are at risk of both IUGR babies and low birth weight babies. If there is poor outcome of previous pregnancy, fine, they are also at risk. If the previous pregnancy child born was IUGR, if there was history of preterm labor in the previous newborn, they are also at risk. Fine. Next is pre-pregnancy weight gain, height, and BMI. This I already spoke about. Maternal undernutrition predisposes the baby for being low birth weight or IUGR. Fine. So maternal malnutrition at risk of IUGR babies. Next is occupation, wherein long periods of standing or substantial physical stress might lead to IUGR and low birth weight babies. And there is increased risk in lower socioeconomic status and certain race like non-Hispanic black women. They are all at risk for low birth weight babies. Okay. Again, acute and chronic maternal illness is important, and any other maternal factors like uterine malformation, uterine trauma, etc. might be there as the cause for low birth weight baby. So this was regarding the maternal history, which might be needed taken in detail because you might find any of the risk factors or etiology or clue for the low birth weight or IUGR baby. So we'll have to substantiate the maternal history in more of detail. Okay. Next is antenatal history. Again, I've already told that assisted, that IVF babies are at risk for both twin deliveries might be there, which can lead to preterm, or they themselves are at risk for preterm labor. Fine. Or first trimester, again, infection, drug and radiation. Infection, I did not discuss it in detail over there because we will discuss it over here because it is more pertaining and more important over here. So IUGR babies, we tend to have symmetric IUGR babies because infection affects the baby in the first trimester, correct? So first trimester baby will have symmetric IUGR. Fine. So history of fever, rash and lymphadenopathy is important. And what are the probable infections that can cause? It goes by the mnemonic torch infection, but now they have extended and it is called as torches clap. More organisms have been added. Okay. So T for toxoplasmosis, O for other viruses, which can be varicella, parvovirus, hepatitis B virus, etc. R for rubella, C for CME, H for herpes simplex virus, E for enterovirus, S for syphilis. Okay, so this was to do with torches. Next is clap. Okay, C for chickenpox, L for Lyme's disease, A for HIV in the baby that has been transmitted from the mother, and P for parvovirus B19 infection. So torches, clap, infection, drug and radiation, all the three are important. More so infection. Okay, so baby born might be a symmetric IUGR baby with low birth weight. Baby might have hepatomegaly, baby might have splenomegaly, baby can have rashes, baby can, there are other clues as well which you will get on examination, correct? Baby might have cholestatic jaundice, correct? So these are all the examination findings if baby has had intrauterine infection. Next, second trimester, if the mother is already known or diabetic or HTP, like gestational diabetes mellitus, as such that there might be macrosomia, but if the mother is an already known diabetic, then there is a higher chance of low birth weight in the child that is being born. Okay, HDP can cause uteroplacental insufficiency, so blood might not flow to the baby properly. That can cause again IUGR babies. Okay, anomaly scan is important because again the child, if there is any anomalous child, they are at risk for both low birth weight and IUGR. Okay, and if supplements has been taken properly or not. Next is third trimester history. So if there is premature rupture, like preterm premature rupture of membranes, so leaking PV will be for a prolonged time. Since there is baby will be at risk of sepsis, they might tend to do cesarean section. So there will be a preterm labor, correct? So UTI and any risk of sepsis in the mother, chorioamnionitis in the mother, they might terminate the pregnancy at an earlier stage. So there might be preterm labor. Fine. And if any other placental factors that were present, like placenta previa, placental abruption, which has caused preterm labor, and history of growth scan, which will show if there is IUGR or not, AFI, amniotic fluid index, like oligohydramnios, and oligohydramnios itself can cause IUGR babies because there is no space for the baby to grow, and if there is any uteroplacental insufficiency. Finally, what was the total weight gain in the pregnancy is also important. So this is pertaining to the antenatal history. And in postnatal history, one of the important questions that you guys will be asked is regarding the feeding in these babies. How do we go about counseling the feeding in preterm babies? Okay, so if it is less than 28 weeks, we either start with IV fluids and we give minimal nutrition or something like colostrum smearing, which you guys will not be asked. Okay, So between 28 to 32 weeks is when we start feeds, that is by the orogastric tube or nasogastric tube. So we put the tube and we start feed through the tube because the sucking and swallowing reflex will not be developed yet, correct? So then between 32 to 34 weeks is when the suck and swallow starts to, the swallowing reflex will come into picture by 32 weeks. So we start giving it by palada or spoon feeds, correct? So between 32 to 34 weeks, it is palada or spoon feeds. And after 34 weeks, the suck and swallow both are developed and it becomes coordinated. So we can initiate breastfeeding. So more than 34 weeks, it is breastfeeding. 32 to 34 weeks, it is spoon or palada feedings. 28 to 32 weeks, it is through OGT or nasogastric tube. Okay, so this is a very important question. Feeding in preterm babies, how do we initiate and how do we counsel the mother? Next is we look for problems associated with preterm birth. So this is the question you guys will be asked. What are the anticipated problems? So we'll go systematically. We'll see each system, what is the problem that can be present. So if it is respiratory system, baby can be at risk for perinatal depression. So baby might not cry. Respiratory distress of newborn can be present. Apnea of prematurity can be present. And due to all these problems, the baby might be at risk of developing chronic lung disease or bronchopulmonary dysplasia at a later stage. Okay. Coming to neurological, the preterm child might not have good respiratory drive for the baby to breathe or cry. So that will lead to asphyxia, correct? So postnatal, perinatal depression can be there. IVH can be there because choroid plexus are not fully developed. Okay. And this IVH can go ahead and cause periventricular leukomalacia. Fine. Next is cardiovascular system. Cardiovascular periventricular leukomalacia, secondary to the asphyxia pattern in the preterm child, is periventricular leukomalacia. Fine. Next is the CVS, cardiovascular system. Again, patent ductus arteriosus can be there. Okay. Hypovolemia they are prone for because there will be increased dehydration, correct? Because of the smaller surface area. Okay. And the cardia itself might not be mature enough. So cardiac dysfunction itself can be there in extreme preterm babies. Now, anemia, there is anemia of hematological manifestations can be anemia and NNHP. Okay, because of hemolysis, NNHP as well can take place. GIT, again, preterm and IUGR babies are at higher risk for necrotizing enterocolitis. Fine. And since the GIT itself is not well developed, they can have feed intolerance as well. Next is renal. They're more prone for fluid and electrolyte imbalance because the kidney is not totally matured enough. It only becomes properly matured enough at 36 weeks, correct? Fluid and electrolyte disturbances, they are more prone for, okay, they're more prone for hypothermia because of smaller surface area. And so there will be increased heat loss. Fine. And immunologically also they are not developed. So they are at increased risk of infection. So early onset sepsis rates are higher in these newborns. Okay. Eyes, retinopathy of prematurity, and ears, hearing loss. Right. So these are the problems associated with preterm births we have seen and we have gone systematically. Okay. Next is question that will be asked for you guys is, what are the long-term problems that we expect in these low birth weight babies? So there can be neurological disability in terms of developmental delay, cerebral palsy, or they can have normal cognitive dysfunction wherein there can be language disorders or single learning disorders. So, okay, all these problems can be there. Or sensory impairment in terms of visual or hearing loss can be present. Okay, then ROP can occur, chronic lung disease can occur, poor growth can be present, or increased rate of childhood illness and admissions. Fine. These are the long-term problems. So these were the acute problems associated with preterm birth, and these are the long-term problems associated with preterm birth. And last question that you guys will be asked is, in IUGR babies, what are the potential complications? Okay, so IUGR babies can have congenital anomalies. Okay, they can have perinatal depression. Till now we saw preterm babies. Now we will see IUGR babies. So they are at higher risk of meconium aspiration because IUGR babies are at risk of fetal distress, and fetal distress means they can pass meconium and cause meconium aspiration. Okay, they are at higher risk of pulmonary hemorrhage. Okay, PPHN, that is persistent pulmonary hypertension of newborns. They are at higher risk of hypoglycemia. Okay, then they're at higher risk of hypocalcemia, hypothermia, polycythemia, and thrombocytopenia. Okay, so these are the potential complications of IUGR babies. And a homework for you guys is this question again will be asked: what is the cause for hypoglycemia in IUGR babies? What is the cause for polycythemia in IUGR babies? And what is the cause for hypothermia in IUGR babies? Okay, this you guys need to know. Fine, this you guys will find out by the end of today's lecture. Okay. IDR, infection, drug, and radiations. Fine. Any other doubts? Repeat maturity. I'll repeat it now. Fine. So by maturity, how are they defined? The newborn babies are defined as preterm, term, and postterm. Okay, so preterm can be divided into extreme preterm, very preterm, moderate preterm, and late preterm. Extreme preterm less than 28 weeks, very preterm is 28 to 32 weeks, moderate preterm is between 32 to 34 weeks, and late preterm is between 34 to 36 weeks. Term is divided into early term, full term, and late term. Early term is between 37 to 38 completed 37 to 38 weeks. Okay, and full term is between 39 to 40 plus 6 weeks, and late term is between 41 to 41 plus 6 weeks. Okay, and next is post term, that is more than 42 weeks. Hope you understood. Any other doubts, or we shall wind up the session? No other doubts, I guess. And if any other doubt is there, you guys can always WhatsApp me your doubts. Okay.